And then when it comes to cath lab, I know stress tests can lead to somebody going there.
Yeah.
Is that the next step? If they fail the stress test, typically sent to the cath lab after that?
Yeah. So with an interventional cardiologist, that's usually the next place you're going to go. If there's any potential for significant risk, and the patients coming to me will often have or give quotes that, hey, they said that I was 100% blocked, usually in the LAD, quote, the Widowmaker. Or I was 90% blocked. I only had 5% function there. And the cardiologist said, let's go ahead and take you to the cath lab. We'll use radio opaque dye and take a picture of your arteries and go ahead and sign for me to do a stent while I'm in there, because we don't want to bring you back out and then take you back in. And that's the standard process. And a lot of people come back out with, they get their stress tests, then they go to the cath lab and they come back out with not only an angiogram, but a stent.
And how do they determine whether or not to use a stent? Is there a certain percentage of blockage they're looking for?
Again, it varies dramatically. And let me clarify something. A lot of people think that I am a cardiologist, an interventional cardiologist. I am not. I'm a prevention doc. I started as an ER doc, back at about the same time as Hippocrates, about 40 years ago, and got very interested in this issue and thought, you know what? I love doing emergency work. It's exciting, but most of these things coming into the ER coulda, woulda, shoulda never happened, but they involve education. So I'm going to go someplace, the best place I can find to understand how to prevent this in the first place. That was Johns Hopkins. I went there. I trained in preventive medicine, loved it, did well. Have a little bit of a brain for, number one, I'll be polite because I grew up in South Carolina, but number two, I also am very skeptical about what makes sense and what doesn't. And it was really clear when I went through my early med school training that so many things were based on a recipe. Dr. Jones says, do this, but where was the evidence for what Dr. Jones was saying to do? I did well at Hopkins, ended up running the program, training other doctors in prevention there. And again, pardon me for diverting into an origin story, but I want to help clarify why I'm not going to answer what each cardiologist decides is going to be his or her criterion for doing a stent. So at Hopkins, I had a blast. I loved what I was doing. And more recently, about 8 to 10 years ago, I was sitting in a weekend seminar. It was really good. It was a couple of $1,000, though. It was very expensive. It was about heart attack and stroke prevention. It was given by a fellow named Brad Bale and his partner, Amy Doneen. And I was thinking, there's this kind of information needs to be made available to the public. I know there are people out there that would be interested in it. It shouldn't cost $2,000. And there's this new technology, this new platform called YouTube, where they'll find the people that are interested for you. And so I started putting the content on, and that's the origin story for my channel. Again, pardon the diversion, but I'm not going to be able to tell you what each cardiologist uses. And I'll also tell you this, as I said before, it's subjective enough and variable enough that nobody's going to give you any clarity in terms of what's actually happening out there. I'll typically hear from patients, they'll come in with emotion saying, it was 90% blocked, 95% blocked, even 100% blocked. And you may know where I'm going next with my question with the patient, and that is, okay, are you running or exercising? Oh, yeah. I do hill sprints. So when you're doing your hill sprints, are you having chest pain? Oh, no. Let's see if we can make the connection here. You're doing hill sprints, your heart rate's getting up to 130, 140, 150, and a doctor's telling you that you have so much blockage to in the arteries to your heart that you need a piece of metal in there. Help me connect the dots here.
I know where you're going.
Where am I going?
The body is smart and it grows new arteries to make up for that blockage.
Collaterals.
Exactly.
There's another thing too. The arteries are not plumbing. They're not rigid pipes. You start to exercise, and the tissue notices a need to increase artery flow. The artery expands. So there's so much hocus pocus to decisions made on when to put a stent in. It's very frustrating. And by the way, I mentioned the standards committees saying there were way too many stress tests done. Guess what they say about stents?
I'm assuming they like them?
No, way too many stents are being done. They say the same thing.
Oh, okay. So they don't like the amount of stress tests or stents, but yet those are standard of care.
Exactly. They're saying that they're saying, well, they are the standard of care for far fewer indications that they're being done for, and they're being done way too often.
Okay. Well, let's talk more about the stent story.
Yeah.
You've alluded to and touched on the fact that they're not all that they're cracked up to be. Talk about that person that fails the stress test, goes to the cath lab, they sign the waiver, they get a brand new stent put in. How is that helping prevent future incidents of, say, a heart attack?
Well, if you look at a couple of trials, one of them was called the Courage trial. I can't remember the name of the other one. If you look at those trials, they were clear head-to-head comparisons. One of them was done in the UK. The story was this never could have been done in the US because of human subjects review. So what they did was this. They took people, a large group of people that were set up for stents. And they said, okay, we're going to intervene when they go into the prep, anesthesia prep for getting a stent. Some people, they went through the full prep, took them into the cath lab, did anesthesia, took them back out, but never did a stent. Other people, they did the stent, and that was randomized. And I have to tell you, I think here's the real reason why it happened in the UK, because of their nationalized health system. Doctors were not getting paid differently. Anyhow, as you can tell from where this is going in this conversation, there was no difference in the group that had the stent versus the group that didn't have the stent in terms of a future heart attack. No difference at all. So the Courage trial showed that. The other trial, whose name I can't remember right now, showed it. So then you have the thoracic surgeons, Philip Avedia's crowd, saying, okay, we got this now. Stents don't work. You got to have a CABG, coronary artery bypass graft. That's the only thing that's going to work. So then they looked at that in a trial called the ischemia trial. And guess what they found?
Same thing?
Bypass didn't help either. These things don't prevent heart attacks.
Any chance either of them cause more issues? Because obviously when you go in and you're putting a foreign object in the vessel, it's going to change the way blood flows. Maybe different molecules, including red blood cells, LDL, HDL, could get caught up on that. And when you're putting in, bypassing, you're going to change the way blood's flowing and how blood flows. So if it's not doing anything, I could see how maybe it's even causing worse outcomes.
Well, you might think that. And again, you might think, given my position on a lot of this, I would look hard for that. And I have looked hard for that. The bottom line is there's very little significant evidence that stents or even stress tests actually do a lot of harm. You might think exactly what you were saying. That would actually be maybe common sense, but it's another area where common sense really doesn't pan out in the data. So one of the things I'll tell my patients, I mean, this is an emotional event when somebody gets told, I got to have a stent or I'm going to die. And patients will come to me all upset, and I'll say, look, if you're looking for me to tell you not to do this, number one, you're coming to the wrong place. You're Luke Skywalker. This is your battle, your life. But I am Yoda, and I've been in a lot of those same battles with your peers, and I'm also one of your peers. I've been in the same battle myself. But I'm not going to tell you what to do. I can't. That's your job as the patient to decide what you're going to do. And if you're thinking I'm going to tell you that a stent or a stress test is going to ruin your life, no. The decisions that come out of that might and often do, with the most common decision being, hey, you know what? I had a heart problem. I had a stent. I got it fixed. That kills a lot of people.
That makes sense. And bypass, same thing?
Bypass, not quite the same thing. I had a patient named Lois that came on my show one time and told her story. Bypass overall doesn't really kill a whole lot of people, but it's not like a stent. It's brutal. You take a saw, you cut all the way up through here, you pull the chest open aside so you can access the heart. You do a lot of damage. And the whole point is to try to put new vessels in there that aren't going to have this problem. At the end of the day, it is the same message. Bypass graft doesn't fix the situation. Metabolic health does. And going through all the pain of getting your chest opened up and then wired back together, I haven't done this. I doubt you've had one of these either, but the folks that have these get their sternum wired back together tell me that it hurts a lot to get back to routine, appropriate exercise. So I do discourage people about doing that. Now, Lois, for example, said, look, Lois shared her story. She has FH. She had high levels of LDL. She was used to arguing with her doctors when they panicked over it. She was used to arguing with doctors who wanted to do stents or bypass grafts. But she shared on the channel or on the show that, you know what? The doctor was panicked, very emotional, and she looked over and her daughter was at the door listening to all this. And she said, I know, I don't want this. I don't need this. It's going to put me through a lot, but I'm just worried that it's going to put my family through a lot more if I don't do it. Well, Lois also had a genetic variation in her blood, in her hemoglobin. When they gave her blood immediately after the bypass, it almost killed her. And she was in a whole different place spiritually because when she and I met after that event, because the bypass, again, is not nearly as harmless or as safe as just a stent. Folks should remember that.
If you enjoyed that clip, you're going to want to head over here and catch the full episode. I'll see you over there.
I started as an ER doc. I love doing emergency work, but most of these things coming into the ER should have never happened. High levels of glucose or even high levels of insulin irritate that